Hi, I'm Carlos de Castro. I'm a professor of medicine at Duke University in Durham, North Carolina. PNH is a very rare disease that is not well understood, but we're getting better at understanding it. It involves clinically three things. Patients can present with some bone marrow failure and low blood counts. They can present with intravascular hemolysis, which is where the blood cells are breaking apart in the blood vessels themselves. And this leads to dark urine and to a lot of symptoms: abdominal pain, difficulty swallowing, fatigue, etc. And then thirdly, patients have a tendency towards forming blood clots. And usually these are in very unusual locations, but can be almost anywhere. And it's the blood clots that we really worry about because those can kill people. So patients will usually take a while to diagnose because the physicians have never even heard of it either. A lot of times they'll present with dark urine and be sent to urologist or to cardiologists for chest pain or to GI doctors for abdominal pain. But eventually somebody notes that they're having ongoing hemolysis and they're anemic, and it takes a blood test basically to, once you have that suspicion, that uses flow cytometry to look for the absence of certain proteins on the blood cells themselves. So management depends a little bit on the symptoms that they're having. For example, for bone marrow failure, we would probably use immunosuppressive therapy, trying to boost up their blood counts. For blood clots, obviously they go on blood thinners. But for the hemolytic form of the disease, we are now managing that with inhibitors of the complement pathway, because this breaking up of the red cells is manifested through our complement system, which is part of our immune system. Whenever complement gets activated, these PNH red cells will burst and lyse in the blood vessel. Sure. So with PNH, we have now 4 FDA-approved inhibitors of complement. This is focused on one of them called Pegcetacoplan, and it is a 3-year or up to 3-year follow-up of one of the phase 3 trials and an up to 2.5-year follow-up of the second phase 3 trial, where we combine the data to look at how patients are doing, how efficacious the drug really is, and how safe it is. The general conclusions are it is very effective, even up to 3 years, in terms of raising hemoglobin and avoiding transfusions. And in terms of the side effect profile, it really hasn't changed from the initial studies that we did when it was FDA approved. The side effects are very tolerable and manageable. And so we're very happy with this drug in terms of how it's doing now as a treatment option for PNH. So this drug was developed as what's called a C3 inhibitor, part of the proximal pathway. The drugs that had been there previously were C5 inhibitors, and these are in the terminal pathway. The C5 inhibitors were very useful in terms of blocking intravascular hemolysis, which was the main manifestation. But about 10 to 20% of those patients were what we call suboptimal responders. They were still anemic. They would still require transfusions. And so this drug came along and really was very efficacious in that patient population because it blocks both proximal and terminal. We didn't have extravascular hemolysis with this new agent, Pegcetacoplan, and therefore we saw improvements in hemoglobin levels. We saw improvements in transfusion avoidance with this drug. And the question becomes now is, which drug should we use up front? And I don't think we know the answer to that yet. I think they're both very good drugs. So I have a hard time when people ask me which one should we use. Now, one is given as an IV administration every 8 weeks. Pegcetacoplan itself is given as a subcutaneous home infusion under the skin twice a week. So it is a little more often. They do have a new on-body injector, which you can use very easily and not have to set up the old pumps that they used to have. So that is a little bit easier to use, but it does have to be given twice a week at home. No, I think, again, when we look at this drug, it's showing now data. One of the advantages of the older drugs was we had a lot of data over the years since they've been out, over 15 years now. This drug was newer, and so we didn't know long-term data. Now we're starting to see some of that, and it's still showing a good deal of efficacy and a good safety profile. There is going to be a lot of ongoing learning programs because I don't think we have the answer, because as I mentioned, there are just a recently approved new drug for treating it that acts at a whole new target, factor B. And there's several others coming out that are going to be acting both at the old C5 and at newer targets in the complement pathway. And which one is going to be the one that should be preferred or is superior, I don't think we know yet. So there's going to be a lot of questions and a lot of education that'll have to occur with these.